Assalamu alaikum, ladies, gentlemen, dignitaries, guests, colleagues, friends. Thank you very much for giving me this opportunity to speak. I thank IAS for bringing us together. The International AIDS Society has brought National AIDS Society together, and I think we should take advantage of that and make some critical, decisions which can make lives better for people who are underserved. So, my topic is linking and staying linked in Pakistan. Lessons learned, how to reduce follow-up. I mean, it's one of the most challenging things currently in Pakistan, particularly from the perspective of people who inject drugs. And we are, despite having doing this work for the last almost 12, 13 years, we are still facing challenges that, we're not happy about it, that we can do so much, but we are unable to do that. We know the people where they are, we know the medicine is available. It's just the linkage that is being challenging. So we provide, we link HIV positive PWID and their spouses across 58 districts of Pakistan with the care and mobilization of them to actually understand the need and then take it up has been, has been a hallmark of the overall services. Rather, we started with harm reduction programs alone, but we saw that the biggest gap is to actually, when we identify people, it becomes a bit difficult to link them up. So we came up with several strategies, which I will be discussing later. Basically, absence of OMT has compounded this problem much, because most of the people remain under the influence of drugs, not stabilized enough to understand the need for ART, and they generally get lost to follow-up, which is a word which I have to use, but I think the medicine has lost to follow-up to the patients rather than patients losing follow-up. So in terms of the situation, I would like you to focus on these three lines. And the green line is about people who are on ART. The red line is for people who have lost to follow-up. And the black line is people who are no more here. So the problem, if you see the Punjab chart, what we are seeing is that the number of loss to follow-up is regularly increasing. So these are 6 months bracket, starting from January to July to December 2020 as a baseline, and every 6 months we are losing more and more people. If you look at the red line, and the number has reached to 1,850 people lost to follow-up, which means that they were on treatment in the past 6 months, and they are no more on treatment in these 6 months. And it's a huge gap. And I can see these lines might get crossed with each other at some point in time, because the loss to follow-up is so huge that we are putting up 1,800 people on treatment almost in 6 months, and 1,800 people are leaving the treatment. So it's not a good idea to keep doing this. In Sindh, the situation is a bit better. The gap between loss to follow-up and people retained on treatment is bigger, and we feel that it will keep getting wider and wider with the new strategies, which I will be discussing later. Khyber Pakhtunkhwa and Balochistan, we are fortunate that the disease burden is still low, and there we are managing quite okay, but we should see pockets where we need to initiate differentiated services to make sure that similar things do not happen in those provinces also. So this is a picture which is particularly grim about Punjab, and rest of the provinces we are trying to manage. Strategies, we have, from the start of this project, we have brought so many strategies to actually make sure that people who are identified HIV positive, which is a huge number, and because we arrived late in many districts, and we are finding new infections among people who inject drugs who are new to the program. We installed in 2013 dedicated staff, which is known as social mobilizer, to take care of all the HIV positive people, to take them for baseline investigations. We brought in the budget for transportation, we brought in the baseline investigation costs to make them register to ART, ARV issuance, and then the strategy that we came up with was ART adherence unit, which without which we would not be able to link even these people who are currently linked, because OMT is not there. So all these efforts, then there's an InTouch program which follows up people who have been to ART adherence unit and then go back to the community. So we follow them up telephonically, we follow them up with the staff. So and then we have been developing so many proposals time and again to find out the best way for differentiated services, which include hiring mobile teams, doctors trained and go in the field. They should have ARVs. We requested UNDP and the Global Fund to, for the refill at least, ARVs should be with us so that we can make them available to the clients at their doorsteps. That proposal was, on the condition with the consent of the provinces, and then could not fly. Then we changed the proposal with the Punjabs, where their doctors agreed to come to the spots, and we budgeted that and all, but at the last moment, it could not happen because of some, difference of opinion. Because they wanted only the lost to follow-up clients to be treated in the field, and rest should still come to the ART center, which was not a good idea, because telling people that if you cannot go, you'll get medicine here, and if you can go, you will not get medicine here. That's from the dynamics, field dynamics, it was not possible. So we had to again shift it to another strategy which currently is working in Sindh, which I am telling you now. So this is what we are doing in Sindh since last 6 months or so. There are 3 medical doctors, there are 3 mobile vans which travel to the districts, depending on the number of clients in that district, and they get the ART medicine issued, thanks to Dr. Sikandar, who is sitting here, and Dr. Waas, who has coordinated this, that we are able to do this, and this is going very well, but it's too early to show the results from there, but we can still see many positives from there, which I'll be explaining later. So we have one vehicle which covers the districts which are very small in numbers, in terms of the number of clients, because Sindh we arrived early and we were able to make an impact. Other than Karachi, most of the Sindh we have very low HIV prevalence. We have very few clients who have been identified as positive. We have almost negligible incidents now, and we don't find new clients even if we try hard. So that's a success story in Sindh, and even in the spouses the infection has not been transmitted. So one van goes to all districts which are in the interior, and 2 vans are dedicated for Karachi and 2 districts, Chatha and Badin, and one is Karachi and 2 districts, which is Mirpur Khas and Hyderabad. So this is how we have distributed the load. So all 3 vehicles need to see something like 500 clients each in a month to provide them refills, to do the general checkup at the spot, at their homes, or bringing them to the COPC site, whatever is convenient for the clients. And we are seeing that loss to follow-up has started decreasing. Some of the lessons learned from this intervention, which I'll try to summarize here. First of all, the most important thing, the clients are very relieved and very happy that they are getting medication at their doorsteps rather than the travel that they would need to go to the ART centers under the influence of drugs. So that is something, the most positive thing. Then there's an improved relationship with the CDC HIV, We have an MOU with them. We have a complete SOPs available for this project, how the medicines will be issued, how those will be reported, and there's a regular interaction between the ART physicians and the doctors who are providing services through these mobile units to see where the gaps are, and the data analyst also we have placed to look at where the need is and where how the route should be formed and all. Then we have found this approach very, very helpful in reinitiating ARVs for clients who are lost to follow-up, who are reluctant to go to the ART centers and have stopped using ARVs. So 164 such clients so far have been reinitiated on ART with the ART centers. Then early reporting of any health complications that they, since the medical doctor who is trained by our Khan, and we had a very comprehensive training there, so they know the dynamics of the problems of people who are on ARVs, opportunistic infections and all. So they just keep checking them and link them as soon as possible with the relevant ART physician at the ART centers, and they start taking the treatment. Then availability of latest viral load testing. We do point of care viral load testing, so all the doctors are equipped with the latest viral load testing results to make wise treatment decisions for the clients in consultation with the ART physicians. Then we are seeing a significant reduction in loss to follow-up. I'm telling you that it's only been less than 6 months that we have initiated this project, and as soon as we completed the next 6 months, the charts that I have shown will have a different, different picture now. That's what we see. And then regular and instant data synchronization between ART MIS and the NZ MIS, which we are always trying to do so that everybody knows what's happening. Some of the recommendations are that similar needs-based differentiated services should be employed in all high-burden districts. Maybe whichever province it is, but Punjab in particular, where the number is very high, and despite Punjab has expanded ART centers, I mean, to go to the ART centers for a drug user has always remained a problem. And it's not that some people don't go, sometimes some people can go, sometimes some people cannot go. So we have to take care of all of them, and providing them medication at their doorsteps would greatly benefit in making them adhere to ART. Then the removal of condition of CNIC. There is a condition in Punjab for CNIC at the time of registration, and we all know that drug users are not likely to have it. Maybe other key populations have the similar problems, and conditioning a right to health with the, we are all okay with this, and we understand that it's very important to document who has come for the treatment, but not at the cost of not giving them treatment. So we can find ways of making them understand this need and get their CNIC made. So we should understand the context. So in Pakistan, I mean, how can you expect a drug user to go and get the ID card first and then come for treatment? So until such time that they don't get it, we should continue providing treatment. The differentiated service delivery mechanism should be used for ARVs refills for other PLHIV to save them from long distance travel. And there's proposal from CDC Sindh that, since our vehicles are going already in various districts, so why not start covering PLHIV who are HIV positive, who needs ART refills and have to come to collect it? So can we just add that in the same group? So that is under consideration. Hopefully very soon we'll find ways to integrate both services. Then the data should be reconciled jointly to see where are the gaps, so that we can make changes accordingly. Interoperability of MIS, ART MIS and NZ MIS is under discussion, and we soon will have something in that direction. Punjab remains a concern again, because we would like to also integrate their MIS. So basically, you know, the last to follow up is something that we are discussing in almost every meeting, and are we doing something about it? So this is the only intervention in this direction so far, as far as PWID is concerned, and this seems successful, and we want that to be replicated elsewhere, especially in Punjab, because the burden, almost 80% of all PWID that we reach are in Punjab, and almost similar proportion is of HIV positive people. So it's a huge need, and we as Zindagi are trying very hard to remove any hurdles in the direction of getting treatment to the clients, and we would like all of the people here to join hands and make this available. And I think all of us understand that differentiated services is the solution to loss to follow-up, and that's where we have to go. How long we take, we might lose many lives, or we might lose many clients who are on ARVs. So the clock is ticking, and it's happening every day. The number of 18,000, since I developed this position, 1,800 people going out of treatment in 6 months. I think we are doing a disservice rather than actually doing something for them. And putting them on ART, promising them that we will provide them lifelong, and then not giving it is not fair for the client. So that's all I have to say about this, and let's hope that we all make a difference. Thank you so much.